All right, well, thank you so much.
Thank you.
We will go ahead and get ready and move on to the next speaker then. And I am doing this introduction. Okay. So Dr. Liza Ashbrook is a neurologist and associate professor of neurology in the Weill Institute for Neurosciences in the School of Medicine at the University of California, San Francisco. She's also the director of the Sleep Medicine Fellowship Program at UCSF. Dr. Ashbrook's research focuses on understanding the genetics of extreme circadian traits and extreme short and long sleepers, as well as characteristics associated with these sleep and circadian phenotypes. A recognized expert in her field, Dr. Ashbrook speaks frequently nationally on common sleep disorders such as sleep apnea, excessive daytime sleepiness, insomnia, restless leg syndrome, and REM sleep behavior disorder, and their relation to Parkinson's disease. She also gives talks on sleep and women's health. Dr. Ashbrook earned her medical degree and completed her residency at UCSF. She completed a fellowship in sleep medicine at Stanford University. Dr. Ashbrook is a member of the American Academy of Neurology and American Academy of Sleep Medicine. Her research has been published over 90 times in scholarly peer-reviewed journals, including the journal Neurology. A practicing physician, she treats neurology patients suffering with sleep disorders at UCSF and the VA. So thank you very much for joining us, and I will turn it over to you. Oh, I can't hear you. We heard you earlier. Anyone else here? It's not just me, is it?
No, we can't hear her.
Okay, thank you.
No. There's something with the mic probably on here.
Yeah, probably the audio options.
Yeah.
These things have a mind of their own.
All right. Are you able to hear me now?
Yes.
Yeah, my apologies. Wonderful. Okay, so thank you so much for having me. It's such a pleasure to be here to speak with the group. I'll go ahead and share my slides. All right. So I am thrilled to speak with the group about human circadian variation, specifically directed about personalizing sleep care for well-being. So we are going to focus today on sleep timing. You've already heard quite a bit about the importance of the quantity of sleep and things that might impair the quality of sleep, namely sleep apnea. But these are three things that are really vital to making your sleep good, which is something, of course, we're all striving for. So when we think about sleep timing, many times people will think about morning larks and night owls. And so you in the audience can think now, are you a conventional sleeper? Are you a morning lark? Are you a night owl? Some of the questions that are helpful to dive into this is, what is your preferred sleep timing when you're free of obligations? When you don't have other people telling you time to go to school, time to go to work, the need to take care of others or yourself. At what time do you focus the best? If you need to do a big project for work, when would you choose to do it? If you have to do a grueling workout, what time of day would you best perform? All of these can help you determine what your chronotype is. So let's talk, what is chronotype? This is a unique daily activity pattern for each individual, and there are a lot of factors that help determine your individual chronotype. So one is your circadian rhythm, and there's a big genetic contribution to that. But there are also environmental factors, lifestyle factors, and age. And so we'll dive into these. So this is a curve showing the variation of chronotype throughout the population from Till Roenberg's research. And you can see that there's a relatively normal distribution. So while most people are conventional chronotypes, there are people at the extremes on either end. And as we become more extreme, there are fewer and fewer individuals. And this is based on the mid-sleep time that's corrected for work week sleep deprivation and for sex and age. So when we think about chronotype, a really important component to talk about is circadian rhythm. What is circadian rhythm? So this is an endogenously generated rhythm of circa a day, as many in the audience I'm sure know. And it's so vital to living organisms because it helps us anticipate what is happening next. When should we expect to eat? When should we expect to sleep? When should we expect to be safe? When should we expect to have to protect ourselves? And so much of our body really functions based on time of day. Our liver needs to know if it should expect to produce sugar to avoid hypoglycemia, or if it should expect food input during that period of time. So you might imagine that our brain's internal rhythm is exactly 24 hours to match up with the day. Interestingly, on average, studies show that human circadian rhythm is just over 24 hours, or our period, as it's called, 24.2 hours. That there is certainly variation person to person. And it's our suprachiasmatic nucleus that is our central pacemaker. This is located in the hypothalamus, and it's important for controlling and influencing many bodily functions and their timing. So of course, sleep and wake is a component that we think a lot about, but there's also many other things, including the core body temperature, which is something that's often measured in clinical research surrounding sleep timing, cortisol release, appetite. And circadian rhythm has actually been described for centuries. A study done by a French scientist back in the 1700s on a mimosa plant shows both the longevity of the awareness of circadian rhythm and how it affects not just humans or animals, but plants and many, many species. So the mimosa plant, this scientist noted, had open leaves during the daylight hours in the sun and closed its leaves at night. So he then went on and moved it to an environment where it didn't have sunlight and noted that it continued to cycle in that same way. It in fact wasn't responding solely to the light, it was responding to the time of day. When we think about the circadian rhythm in humans and the function of the suprachiasmatic nucleus, a really important piece is thinking about what are the inputs to this rhythm. And so for humans, the really main input is the timing of light. And this is demonstrated when we think about these specific kinds of cells in the retina called intrinsically photosensitive retinal ganglion cells, or IPRGCs. And so right at the back of our eye, we have these cells, and they have a direct pathway to our central circadian pacemaker, the suprachiasmatic nucleus. And what's so important to note about these cells is that they have something in them called melanopsin, which is specifically sensitive to light in the 480 nanometer portion of the spectrum. So this is blue light, blue indigo light. So that's why there's so much in the popular press, in research, in many areas talking about blue light and how it can influence wake and sleep, because these IPRGCs in our retina are specifically responsive to blue light, and they have a direct pathway into the SCN. And then the SCN has many, many pathways out, including a multisynaptic pathway to the pineal gland. It is the pineal gland that releases melatonin. And so we can sometimes measure melatonin in an individual as a proxy for where the suprachiasmatic nucleus thinks it is from the perspective of time of day or proximity to sleep. So light is so important for our internal rhythm, but it's not just exposure to light haphazardly. The timing of light exposure is what is so vital. So we can see this with a nice diagram here on the left. So say one's typical habitual sleep period is kind of a conventional timing from 11 to 7. That means that the core body temperature minimum would be expected to be about 2 hours before natural awakening, potentially around 5 a.m. for this individual. And then dim light melatonin onset. This means when our body naturally starts to release melatonin in dim light conditions is usually 2 or 3 hours before natural sleep onset. So the timing of our exposure to light can influence what time of day our brain thinks it is or where it should expect to sleep. Light in the early morning hours, in the last 2 or so hours of sleep and the first several hours of wake, has the impact of advancing our rhythm, meaning telling our brain, oh, hey, now it's daytime, and helping us to potentially fall asleep earlier. Light in the other portion of time, meaning the last several hours of the day and the first 2/3 or so of our night, has the impact of delaying us, telling our brain, hey, it's still time to be sleeping, and pushing our sleep period later. This is the depiction of the phase response curve to light. Time 0 here is our core body temperature minimum. So that's the time approximately at which this flips from light being something that delays us to light being something that advances us. For most of us, we are able to balance out light at different periods and stay on a stable schedule. But we really think about this timing when individuals are having unrefreshing sleep, having problems with their sleep timing. There's also a phase response curve to melatonin. So while light is the biggest input to our circadian system, melatonin can have phase shifting properties as well. As you know, melatonin is the hormone our body naturally produces in the dark during night hours. And the phase response curve to melatonin is about 12 hours out of sync with light. However, in this period of time when our body naturally produces melatonin, it doesn't have significant phase shifting properties. But melatonin in the early morning hours can have the impact of delaying, at least in experimental conditions. And melatonin in the few hours before our body naturally releases its melatonin can have the impact of advancing our rhythm. So we'll often recommend this to patients who are having trouble with what we call delayed sleep phase, having trouble falling asleep at the desired time and trouble awakening because their rhythm is later than their desired sleep time. You can actually take a low dose of melatonin early before dim light melatonin onset and pull the rhythm earlier. Typically, we recommend a small dose, 0.5 milligrams, which is closer to our physiologic dose, what our body might release. Interestingly, when I see patients in sleep clinic and people are often come in taking melatonin and doses vary widely. But I think it's very important to keep in mind, while melatonin is often taken as a sleep aid to help with sleep, it does have these circadian shifting properties. So for example, if one took 10 milligrams of melatonin, it actually has residual effects in the morning. And if you're trying to take it to pull the rhythm earlier, there may be a spillover effect, and it's actually less potent to do this. So I wanted to share this study by Ken Wright and colleagues from about a decade ago. It's a very small study, but I think it does a great job of illustrating the impact of light on our sleep. So he had individuals sleep in 2 different environments: in their natural environment with their typical amount of artificial light, and then camping without artificial light. And this on the right here, you can see, is a actigraphy. So actigraphy is like a medical grade Fitbit. It collects information on light and movement. And so you can see their first week. This is just a single individual who's representative of the group. You can see the movement and light exposure. And then you can see in the second week, there's significantly more light as the individual was in an outdoor environment. And then they did a circadian phase assessment at the end of the first week and at the end of the second week. So let's look at what that showed. So here on the right, you can see the summary of that information. And to help orient you to what we're looking at, this black bar was the mean sleep episode, the timing of the mean sleep episodes for these individuals in the electrical lighting condition, just their typical life, and then in the natural light condition when they were camping. And you can see as a group, all the individuals moved earlier when they weren't exposed to all the artificial lighting and were exposed to natural light. Not only that, but you can see these error bars, they're much smaller. So there's a lot less variation person to person in this natural light condition. So even individuals who were rather delayed with a later sleep onset and a later sleep offset time moved significantly earlier and were more similar to their peers when not in the electrical lighting environment and instead in natural light. The final thing I think that's useful to highlight is the melatonin timing. So they measured melatonin onset, midpoint, and offset. And you can see for people sleeping in the electrical lighting environment, their melatonin offset, meaning, melatonin is released, and then when there's no longer melatonin detectable in the system, it's actually after they awaken on average, which means they still have some melatonin in the system when they wake up, as compared to those sleeping in the natural light environment. And so this might contribute to some of the sluggishness and sleep inertia that people experience often in the morning in our current environment. Here on the left, I think it's useful to look at this also from the same paper, which highlights how strong different light sources can be. A common term used to describe light in these studies is lux, which is a measure of how strong light is when it hits the eye. And so electrical lighting is often a couple hundred lux up to maybe 1,000. And then natural light, even on a cloudy day, it's 10,000 or more lux. So this scale is not linear. It's an orders of magnitude greater when you're having outdoor light as compared to electrical lighting. So it's not only light that can influence our rhythm. Other features called Zeitgebers or time givers are also important, though we think most about light because it is the main input to the SCN. But the timing of social interaction, meals, and exercise are important. And so we want all of these to line up when we're trying to optimize someone's sleep pattern. So our chronotype, or our ideal sleep pattern, can actually change throughout the lifespan. And I'm sure many of you in the audience are well aware of that. And I think it's nicely highlighted in this graph here. So this is a population study. The youngest age captured here is age 12. So you can see that younger individuals, and age is here on the x-axis, chronotype on the y-axis. The black circles are women and the open circles men. You can see that younger individuals are earlier chronotypes, and then abruptly shift later during adolescence, peaking around age 20, 21 for men. So you've probably experienced this yourself or seen your children shift dramatically later during adolescence. And that's something that's seen population-wide. And then following adolescence, we slowly shift our sleep timing earlier. And in older adulthood, people are often actually quite early birds. Sometimes it's a complaint people come to sleep clinic with, not realizing it's kind of the circadian shift that we see throughout the population. You can also note from this graph that during much of adulthood, men have slightly later chronotypes than women on average. So I think it's useful to touch on the transcription translation feedback loop that is core to our circadian clock. So there's a number of genes, clock genes, that are vital to our internal clock. And to highlight a few of these, we have PER and CRY2, whose transcription is activated by a heterodimer clock and BMAL. When transcribed, they then heterodimerize, come back and inhibit clock and BMAL. So they're inhibiting their own transcription. Over time, they degrade and then are transcribed again and cycle through this. And this follows a 24-hour rhythm, allowing for our 24-hour circadian rhythm. And you can imagine that mutation in one of these core clock elements that impacted how tightly binding was or how quickly these are degraded could influence one's internal rhythm or the period of that rhythm. And we do see that. So at the extreme ends of the normal distribution of sleep timing, we can actually see single gene mutations that lead to these circadian phenotypes. So for most people, it's a contribution of many different small genetic variations that are contributing to our phenotype. But in a few families that have been described, single gene mutations can do this. So this is a family that actually colleagues here at UCSF worked with when they were in Utah 2 decades ago. This woman came to sleep clinic, complaining of waking up very early. She had always been an early bird. It hadn't bothered her, but as she got older and older, she was getting progressively earlier and earlier. And now was finding that she was tired in the afternoon and awakening at 2 a.m. She also noted that this extreme early bird tendency ran throughout her family. So you can see here, this is a pedigree of the family with the black circles and squares noting affected individuals. And this trait was passed down in an autosomal dominant pattern in this family, this extreme early bird trait. And the team went on to describe a mutation in the PER2 gene. You can remember that that's a core clock gene, had been described in animal models, and with this family was described to influence the clock in humans as well. So these are traits in most individuals that are neither positive or negative necessarily. But sometimes people are upset about these sleep traits. So what's the difference between simply a trait and a disorder? It becomes a disorder when someone complains about it, when they are upset by what that pattern, or the impact of the pattern on their daily life. So an individual with delayed sleep-wake phase disorder often complains of trouble falling asleep and trouble waking up in the morning. So if somebody has this delayed sleep pattern but has found a job where they awaken at noon, go to work at 2, and aren't bothered by this sleep pattern, then it wouldn't be a disorder if they were feeling that their sleep was adequate, refreshing, feeling satisfied with the situation. But very commonly, individuals have to wake up for school or work, aren't able to fall asleep, and are getting inadequate sleep with a delayed schedule. Advanced sleep-wake phase disorder individuals are less likely to come into our sleep clinic and other sleep clinics compared to those with delayed sleep-wake phase disorder. We have a society where we say the early bird gets the worm, and many people aren't bothered by having slightly earlier time to bed and earlier wakening. But it can get quite extreme, as I described for the woman in the PER2 family. And thus we do see people coming in complaining of evening drowsiness and early morning awakenings, especially as people age. These traits can become more disruptive because, as you recall, as a society, as a population, chronotype shifts earlier. So this is a 17-year-old, this is a sleep diary that she provided. And she complained of trouble falling asleep. And oftentimes when people have complaints and there's concern for insomnia or a circadian rhythm disorder, part of the evaluation in sleep clinic is a sleep diary. This is the sleep diary the American Academy of Sleep Medicine has available on their website. And you can see it includes shading when sleep occurred, a line when getting in bed, and then noting down when medication or caffeine are used. And of course, noting the dates and the type of day. So you can see that this individual is often getting up at the same time, potentially by alarm, but some days sleeps in much later. She's not falling asleep typically until early morning hours, 1, 2, 3, 4, and thus on many days not getting very much sleep. So how would we treat someone who had delayed sleep-wake phase disorder as this 17-year-old does? So this is a schematic of the common treatment approach. So as we've discussed, light is so vital to telling our brain what time of day it is. So a common recommendation is getting good sunlight in the morning hours, at least 30 minutes immediately upon awakening. Sometimes sunlight isn't easily available. Someone says getting outside is just unrealistic. While they may try to sit by a window that likely isn't quite as strong, or it certainly isn't quite as strong. And so a light box can be a substitute. And this is a picture of one example, but there are many different types of light boxes that can simulate sunlight and be used in the indoor setting. While 30 minutes is a common recommendation, there are certainly individuals where it's not adequate, and more light, several hours of light in the morning, or even an alarm light box that actually starts before waking can be used. And then, of course, thinking about exposure to light in the evening, it's very important to have dim light in the evenings. And so we recommend turning down lights and avoiding bright light, even sometimes wearing these orange or red tinted glasses that can block blue light for individuals who are sensitive to evening light and have a delayed sleep period. And finally, an important component of treatment is low dose melatonin. Melatonin is not as strong as light, as we discussed, to shift circadian rhythm, but it can be used, traditionally given 5 hours before natural sleep onset. And as you recall from the phase response curve to light, that allows it to have maximal input on circadian timing. So depending on the situation for the individual, it often works well to start at someone's habitual sleep timing and then slowly shift their sleep timing earlier by approximately 30 minutes each week, using light in the morning and dimmed evening light and melatonin to help move that sleep period earlier. Not pictured here and not as well researched is the importance of timing of exercise, social interaction, and meal and any food intake, in fact. And those should also be timed to march earlier and correlate with the timing of the sleep period. You can actually have internal dyssynchrony. If you're eating during the period where your brain thinks you should be sleeping, you can get your gut on a different clock than your brain, and that's actually been shown to have negative health consequences, increased risk of glucose intolerance, for example. This is another patient, a 42-year-old woman who came in complaining of evening drowsiness. She wasn't able to stay up with her children and partner in the evenings as easily as she'd like to. So this is actigraphy, as we looked at before, medical grade Fitbit showing activity and light patterns, and is used to approximate sleep timing. So you can see that she's going to bed between, say, 8, 7:30, and 9 or so, and getting up around 6, around 3 on some days, up to, say, 5, 5:30 other days. So her timing is shifted earlier, and she was found to have advanced sleep-wake phase disorder. So let's talk about what we might do to treat this condition. So if you remember the phase response curve to light, our goal for someone with advanced sleep-wake phase disorder is, in fact, to delay them, to help their brain think that the day continues on, and that the habitual sleep period should be shifted later. So actually, for these individuals, we focus on light in the evening. I think many people have read a variety of articles about sleep in the popular press and think that light in the evening is inherently dangerous or evil. And certainly many of us are sensitive to evening light, don't get adequate light at other times, and it does delay us. But for this population of patients, we can actually use evening light for therapeutic benefit. So while the exact timing and duration still needs better research, often a recommendation of 30 minutes of a light box in the final hour or 2 hours of the day can help shift the rhythm later. And then avoidance of morning light may also be useful, though that's not been as well researched. So what is the actual risk associated with sleeping at an adverse circadian time? So the group of individuals who this has been best researched in are shift workers. And you've heard a small amount about shift work in the other talks today. So about 20% of those in industrialized nations do some sort of shift work, as defined by work which requires you to be on during periods that you would traditionally be sleeping. And the exact prevalence of shift work disorder isn't clear because many people don't come in to actually complain about it, as they attribute their dissatisfaction with sleep or with ability to stay awake during work or during hours awake with their shift work. But there have been a number of negative health effects associated. I'm not going to go into all of them, but I think this highlights the impact on cardiovascular disease. So this is a large meta-analysis where they found that shift work does increase the risk of cardiovascular disease, including coronary heart disease, myocardial infarction, and stroke. And so those who do shift work, we know they get less sleep. If you're trying to sleep at an adverse circadian time, for example, someone who works overnight trying to sleep during the daytime, they aren't going to be able to get as much sleep typically. So as you've heard about the negative health risks of shorter sleep, you may think that, is this effect actually about shift work, or is it solely about not able to get adequate sleep? And that's what's driving this. So that's a great question and something others have been wondering too. This study from about a decade ago, I think highlights the impact well, that it's not only about sleep duration, but also about shifted sleep. So here, 26 healthy individuals underwent a protocol where they had sleep restriction. They were given only 5 hours opportunity to sleep daily for 8 days. And there were 2 different groups. There was the overnight group, those who are allowed to sleep overnight in a manner that's aligned with their typical sleep and with their typical internal rhythm. And then a group that was delayed. They were forced to sleep 8.5 hours out of alignment. So the 2 groups had similar sleep duration. That's because they were sleep deprived. If you didn't sleep deprive them, we would likely see differences in duration between the 2 groups. And it was shown that those who had circadian misalignment and short sleep had greater metabolic impairment. So a decrease in insulin sensitivity in this group who had the circadian misalignment. Also an increase in CRP as compared to the group without misalignment. So the thinking is that both shorter sleep and circadian misalignment contribute to the negative health outcomes associated with shift work. So the final area that I think is really important to touch on when we think about sleep timing is sleep regularity. This is actually a relatively more recent area of focus within sleep research. There's been quite a lot of work on sleep duration and the negative health impacts of long and short durations. But now there's increasing research on sleep regularity. And the National Sleep Foundation came out with a consensus statement just last year, sharing that consistency of sleep onset and offset timing is important for health, safety, and performance. Nonetheless, when insufficient sleep during the work week occurs, catch-up sleep can still be beneficial. And I want to share a couple specific studies to highlight what's been shown recently about sleep regularity. So in this study, this was a population study of individuals in Tennessee, and actually they included a nice demonstration of what it can mean to have sleep irregularity. So this are just 2 example individuals are sleeping approximately the same duration in total. However, exactly how much sleep they're getting each night is not the same. So the individual in red has approximately relatively stable duration of sleep, whereas the individual in blue has a lot of variability. From day to day, the sleep duration varies quite a lot, despite it being a similar time overall. So this study showed, at least in a population sample, that greater variability in sleep timing correlates with a number of health problems, including neurologic problems, breathing problems, pain, gastrointestinal disease, and depression. This is another study looking at sleep regularity and cardiovascular disease. So they had over 2,000 patients and they had them wear a wrist actigraphy. And they looked at a number of measures that are considered subclinical markers of cardiovascular disease. And they did show that coronary artery calcium scores were significantly worse in individuals who had irregular sleep duration as compared to those with regular sleep duration. And then the final study I wanted to show was one around mood, because this is pertinent to mood as well. So this study looked at 50 individuals considered high risk for suicide, and they followed up with them prospectively at 7 and 21 days and repeated suicide assessment, and saw those who had greater sleep irregularity had greater suicidal ideation at follow-up at both time points, with the thinking that potentially sleep irregularity is a marker of greater suicidal ideation. All of these are correlation, but it's possible that these are modifiable risk factors, something that we can intervene on. So in conclusion, There's no single right time to sleep for the entire population, but there may be a right time for your body. So learning to understand what is your internal rhythm, and work with this rhythm. So you can plan work and exercise accordingly. If you're a morning lark, doing your hardest work in the morning, or hardest exercise in the morning. If you're a night owl, you may plan to have your larger focus period later in the day. And sleeping at the optimal time for your body is something that's controlled, or what is the optimal time for your body is controlled by genetics and the environment. So thinking about the impact of light is really vital. And what is your light exposure? Are you getting adequate sunlight during the daytime? What is your indoor light exposure in the evenings? And for many, dimming evening lights can actually have a positive impact on ability to fall asleep at night. Other things like eating in sync with your timing is important and really needs more work, but we do know that internal misalignment can be detrimental. And then keeping the timing of sleep regular day to day clearly is quite important for not just sleep, but for many components of health. So that is all. Thank you so much for listening.